We have several phenomenal speakers tonight from our faculty and also someone from Blood Cancer United, Andrea, who will be speaking. The speakers are all going to give you an update on some incredibly exciting areas in myeloma. All of the speakers are experts in that area. And then have a special treat of having one of our patients who's going to be telling you a little bit about his story. And then we'll leave some time at the end to take some questions and hopefully engage you and answer things that you're curious about. So our first speaker that we're fortunate to have is one of our faculty members from our Long Island campus, Mark Brownstein, who is an associate professor of medicine. He directs the Hematology Oncology Fellowship Training Program and is incredibly active and interested in educating our future generation of experts in hematology and oncology. He is an expert in myeloma and also serves as the associate editor for the hematology section of the ASCO Daily News. He's a member of a number of professional societies, and we're incredibly excited to hear his talk this evening.
Great. Thank you, Dr. Grossbart. Appreciate that introduction. Thank you to Blood Cancer United for all you do for our patients. And thank you, Alan, my patient, for being here tonight. So it's my pleasure to lead the charge for tonight's exciting evening of updates from the American Society of Hematology 2025 meeting that we just had in December. And for those of you who may not be aware, this is really our premier meeting for the scientific and clinical updates in hematology. And tonight, it's the first part in the three-part series. We're going to be focusing on multiple myeloma. And I'm joined by my astute colleagues, Dr. Davies and Dr. Morgan, who are going to lead in with other parts of updates from the meeting on myeloma. I'm specifically going to focus on a therapy called bispecific antibodies that was presented in various abstracts at the meeting. So it's really fascinating to have been part of this field for over 20 years since I was in medical school and working in the laboratory just when lenalidomide was being developed for multiple myeloma. And you can see there's sort of that inflection point at the turn of the century where we're really learning more about the biology of the disease and how to harness immunotherapies to treat myeloma. And we've been improving survival ever since then. And most recently, as shown at the top, you can see we've integrated therapies like monoclonal antibodies that are very specific for targeting plasma cells. And we've built on that by harnessing other elements of the immune system called T cells in the form of bispecific antibodies and something called CAR T cells, which Dr. Davies is going to talk more about. And these are continuing to improve the survival rates for multiple myeloma. So, we sometimes call this the myeloma marathon because when patients are first diagnosed, the goal is to get them into remission for as long a period as possible. And then the disease has these peaks and troughs where the disease can relapse, and then we give newer agents to try to get it back into remission. So our goal after the disease progresses from these asymptomatic states of either MGUS or smoldering myeloma, and someone is diagnosed with newly diagnosed symptomatic myeloma, is to identify the disease as early as possible in order to limit end organ damage, and then prolong the disease remissions for as long as possible, increase survival, and as well as improve quality of life during the course of treatment or maintenance treatment on therapy. This is an example of a typical treatment journey. It may not be your particular treatment plan, but just one particular example, because there are many options, fortunately, that we have in our arsenal to treat multiple myeloma. But typical first course of treatment is a 3 or 4 drug agent that includes a monoclonal antibody like daratumumab, which targets an antigen present on the surface of myeloma called CG38. And that's combined with other agents that also target elements of the multiple myeloma. And then a patient may go on to, or may not go on to a stem cell transplant for consolidation. And then typically we'll go on some form of maintenance. Lenalidomide or Revlimid is the most commonly used agent. And then if they relapse years down the road, we would go on to another line of therapy with the 3 or 4 drug combination like Kyprolis, Pomalyst, and dexamethasone. And where the T cell therapies are currently approved is right now is in later lines of therapy in people who have progressed after multiple prior lines of therapy. But as I'll show you in tonight's slides, we're starting to move these therapies into earlier lines. And the key thing at any point of treatment is to focus on choosing an ideal treatment plan for you as the individual, because we can tailor our treatment to you, the individual patient, based on your individual disease and personal features, whether you have certain preferences for therapy or certain prior toxicities from therapy. what the myeloma disease behavior is itself. You have high risk disease, you have disease outside the bone marrow called extramedullary disease, and what other supportive interventions are necessary, including paying attention to psychosocial needs, emotional support, and diet and exercise, bone support, and things of that nature. Despite all the progress we made, there's still a need for novel therapies in order to prolong remissions, which can get shorter with successive therapies. This is a busy slide showing you the plasma cell in the center and how there are many new targets that we're harnessing for treatment. I'm going to focus on the ones primarily in red on the left there that are targeting two specific antigens. One is called B cell maturation antigen, or BCMA, and that's expressed on the surface. It's present on the surface of plasma cells. It's very specific for the myeloma plasma cells. Another one is called GPRC5D, which is another protein that's very highly expressed on these myeloma plasma cells. And when we target those antigens, that can lead to the destruction of the plasma cells. So one way to do that is through a monoclonal antibody, so something like daratumumab that targets CD38. But another more modern approach is to activate other elements of the immune system called T cells that can detect the myeloma once activated and then destroy it. And so I'm going to be focusing primarily on bispecific antibodies, which bind both to the myeloma plasma cell, but also activate the body's own T cells, which can't detect the myeloma on its own without these antibodies. Dr. Davies is going to talk more about CAR T cells, which are T cells that have been modified outside the body and then reinvigorated in order to fight the myeloma. So I'll primarily be focusing on three bispecific antibodies. One is called teclistamab, one is called linvoseltamab, and both of those target something called BCMA, and one called talquetamab. If we say these 10 times, we finally able to say it without stuttering. But they're all bispecific antibodies, and talquetamab targets GPRC5D. So you'll hear more about these as we go forward. All right, so just before we get into these bispecific antibodies, I just want to give you some basic understanding of how T cells work. So the reason we don't succumb to every pathogen we come across in the environment is because we have an immune system, and part of that immune system is called T cells. These are cells that circulate in the body that help normally fight infection. But in order to fight infections that are far into the body, they have to be activated. So our own T cells are not yet activated to fight multiple myeloma. So we can use these bispecific antibodies that both bind to something specific on the myeloma plasma cell and also activate the T cell to bring them in proximity so that the T cell can also destroy the multiple myeloma cell. And these are called bispecific antibodies. So let's get into actually some of the data that has been demonstrated that led to the approval of some of these bispecific antibodies. So teclistamab, again, is an bispecific antibody that targets BCMA, and talquetamab is a bispecific antibody that targets GPRC5D. Both of these are expressed in myeloma plasma cells. And these were both studied in individual studies as single agents in patients who were pretty heavily pretreated with prior therapies. There was a median of 6 prior lines of therapies. So these were patients who really had limited other options and expected to have shorter survival because the disease was so resistant. And what we saw looking at these bar graphs, which are showing the overall response, meaning how much could we reduce the disease burden, with the green parts of these bars being the deepest possible destruction of as many plasma cells as possible. The study called Majestic-1, which looked at teclistamab, and Monumental-1, which looked at talquetamab, both bispecific antibodies. Both of these showed well over 50% responses and pretty unprecedented survival with these single-agent antibodies in patients who were really very progressed in their treatment course and didn't have as good options. It's worth noting that these agents do have potentially serious side effects. There's something called cytokine release syndrome, or neurotoxicity, that results from the revving up of the immune system when you activate these T cells. But in general, those side effects are very readily managed with preventive agents, and most of those side effects happen very early on. So we give these therapies in little baby doses as step-up doses to try to reduce the risk of those inflammatory side effects. It's also worth noting that talquetamab targets the GPRC5D, which is also found on skin and nails and may cause some skin toxicity as well. But again, we can manage that, and we ask patients frequently about those side effects while they're on these therapies. So what if we were to combine those two antibodies together as one combination therapy? And this was looked at in a study called the REDIRECT, with two T's, REDIRECT 1, that combined both teclistamab and talquetamab in patients who, again, were very progressed into their myeloma. And these data were presented and updated this year at ASH, where specifically they looked at an extremely high-risk population of patients whose myeloma took on a different behavior and grew outside of the bone marrow. And we call that extramedullary disease. And when you look at the overall response of this combination, 79% of patients had a response, with a large percentage of 54% had almost a complete remission. And when you look at this curve, which is looking at the patients that progressed, you can see that the median time till half of the patients progressed was about 15 months, which is really unprecedented if you look in the context of how high risk these patients were for poor response to alternative therapies. So this is perhaps the study that got the most press at ASH. It was a late-breaking abstract, and it was called the Majestic 3. And this was a randomized study, which means patients were separated into one of two groups. And when you randomize patients in a clinical trial, you're asking a question. And the question that was being asked here was, if we compare a bispecific antibody combination, in this case, teclistamab plus daratumumab, in patients who are in earlier phases of disease, in this case, second line plus, compared to a daratumumab-based triplet combination, is one superior than the other? And this is how the study was done. 587 patients were randomized to one of those two groups. Most of these patients were not exposed to daratumumab previously in the second line or beyond. And when we look at the curves for both progression-free and overall survival, they really separated tremendously. You can see that on the top curve in blue, the patients who got the teclistamab and daratumumab, and that was with no dexamethasone, with no steroids, they did much better than those who got 3 drug combinations of daratumumab with either Pomalyst or dexamethasone or bortezomib and dexamethasone. And although this regimen has not yet been approved in second line, currently it's approved in fifth line, I think this study will really lead to its approval this year in earlier lines of therapy. And this is a trend that we're seeing of efficacy of these antibodies in earlier lines. You can see here that if this is early data that was presented last year of looking at these antibodies in first line. And we have a study enrolling at NYU called the Majestic 7, which is looking at teclistamab and daratumumab combinations in first line therapy. And lastly, Dr. Morgan was the site PI for the study that looked at a single agent bispecific antibody as first line therapy. And 86% of patients had a response with just this single agent as their first line therapy, as opposed to using a 4-drug combination as is typically standard of care. So just to wrap it up, I think we are really heading towards tremendous progress in multiple myeloma because of using these immunotherapies. And with that, we can go to the last slide. Thank you for your attention. I look forward to my colleagues' talks.
Our next speaker, we are incredibly fortunate to have Faith Davies with us. Faith is an amazing clinical expert as well as an amazing clinical researcher who has done groundbreaking work in myeloma along with Dr. Morgan. I'll turn it over to her without further ado.
Thank you so much, Dr. Bornstein, for kind of introducing the immune system. And I just want to carry on with that a little bit and talk about CAR T cells. This is just to say I have stolen a few slides from the internet, and so hopefully nobody will give me a hard time about that. So as Mark mentioned, as we have a pretty amazing immune system, if you think about it, it's programmed to fight infections. And essentially, when we get a bacteria or something like that, the immune cells are able to recognize the bacteria, and they're able to activate each other and to kill off that bacteria. And one of the interesting questions has always been, why do the immune cells not recognize cancer cells? And importantly, if we could persuade them to recognize cancer cells, could we harness a patient's own immune system to kill off their own cancer? And so that's essentially what has happened with respect to a CAR T cell. So a CAR is called a chimeric antigen receptor. And essentially what's happened is that we take a patient's own T cell, we take it out of the body, and in the laboratory, we change it and re-engineer it or reinvigorate it so that it can recognize a patient's myeloma cell. And as Mark says, we have a number of different ways of doing that, about essentially sticking a flag on it to say, hey, please recognize this part of a myeloma cell. And I think many of you will have heard about this before. There was a big article in the New York Times last June, really discussing how patients who'd had this as essentially a last-ditch attempt, they'd had all other myeloma therapies and their myeloma unfortunately had come back. And they had this therapy, and many of them were still alive and well 5 years after having the treatment. And so there's been lots of excitement about this approach. One of the kind of problems, if that's the right expression, is that it's actually a very complex approach. And if you think about it, it happens in 4 phases. The first phase is that you have to get the T cells from the patient. And so that involves placing the patient on a machine that's a bit like a dialysis machine, I would say, where you can take the cells you want off and then give the cells you don't want back. So it's all done in the blood. Once we've got those cells, we have to send them off to a factory to be altered so that they are activated and so that they're able to recognize the myeloma cell. Meanwhile, we have to prepare the patient and give them a little bit of chemotherapy so that when we give them those cells back, they are able to accept them. The whole process of making the cells takes about 6 weeks. Once we've got the cells back, we give them to the patient. And that's the phase 3, the infusion part. And during that phase, we tend to keep a close eye on the patient for about 28 days. And then we then loosen the reins a little bit, but still need to continue seeing the patient and monitoring them for complications. Because unfortunately, as with everything, there are a number of complications. And you can imagine with this treatment, because it's so very different to some of the other treatments, the complications can be a little different. So at ASH, there was actually a lot of data around some of the advancements in this area. And we have 2 CAR Ts that are already FDA approved. Each of these drugs has 3 names, essentially the Sunday best name, a kind of a shortened version, and then a nickname. And so the 2 that we saw a lot of data about are Cytocel and Idacel. They're the ones that have been approved. And we learn a lot about how we should be using them, how effective they are, and a little bit about their management of side effects. But then we also learned some about some of the newer CARs that are being investigated. And I'll show you a little bit of that data. So I'm going to give my punchline now, and then we'll come back to it. But essentially, we were able. The data showed that there were some dramatic responses, even in those patients that have received lots of therapies before. That the responses seem to vary between 70% and 100%, which is amazing. But also that many of these responses were very deep, and patients' disease we couldn't even see using our very sensitive molecular tests. Many patients with difficult to treat myeloma seem to respond. So those would be patients with high-risk disease, or what we call extramedullary disease, where the patient has lumps and bumps. And importantly, there seem to be very long remissions. As Mark was mentioning, many of these treatments now are being brought forward to earlier disease stages. And so there was some data about these products being used at first relapse. And then as well, data about how these drugs are being used in one of the sister diseases to myeloma called amyloidosis. As I say, much data about how we manage side effects, and many of that data was actually from our colleagues where we're all sharing good practice, and then some data about some very brand new products. So let's talk a little bit about some of the brand new products. As I say, there's already 2 on the market, but some of the newer products, what they've been able to do is alter some of the components of the CAR T cell a little bit more so that it's able to recognize the myeloma cell better. But then also some of them are altering the processing about how that happens. So for instance, one called anito-cel, that targets BCMA, so much like the ones that are already approved, but it's able to do it in a slightly different way, using this novel protein, novel synthetic protein. And its advantage of that is that it's much easier to make, so less complex from a manufacturing perspective, but also it seems to have less side effects, which can only be a good thing. A second one that's being looked at is AZ0120. And this one, rather than just targeting one protein on the myeloma cell, targets 2. And so maybe that will help it bind better and be more effective. But also the way it's manufactured is very different. And rather than taking 6 to 8 weeks, theoretically, it can be an overnight process. And again, that seems to, in the early studies, have less side effects. And then the third one targets that other protein that Mark talked about, the GPRC5D, that other target. And again, its advantage means that maybe we now have a number of different ways of killing the myeloma cell. And we've been really fortunate at NYU to take part in many of these clinical studies with our CAR T cell colleagues looking at this. I think the study that caused the most interest was one called an in vivo CAR. And I don't need to get too into the weeds on this, apart from to say the left-hand side of the slide is how we make CAR T cells now. The right-hand side is a potential new way to make CAR T cells. And you can see it looks much easier. Okay, and essentially what was, this was another late-breaking abstract, and there was actually only 4 patients treated, so brand new data, but so exciting because what happens with this CAR T, rather than having to take the cells out of the patient, do the manufacturing, wait 6 to 8 weeks, and then give chemo to the patient and give the cells back to the patient, in this one, they were able to take this vector, this solution off the shelf, inject it into the patient's bloodstream, and it was able to find the T cells and manipulate the T cells within the patient's body. And importantly, the patient also didn't need any chemotherapy. And I think what was really quite interesting is all 4 of the patients had an amazing response. So this potentially has the potential to change things from something that's going to take 6 to 8 weeks and needing a manufacturing plant to something that might be able to be done in the hospital. As you can imagine, I mentioned that everything has some side effects, and they're quite unique for these kind of products. And one of the side effects that is very tricky is that when we give these T cells back, they're very activated. And unfortunately, as well as hitting the myeloma cell, they can sometimes target other cells. And so there was lots of discussion between colleagues about how we can minimize this, how we can recognize some of the side effects and what the best way to manage these side effects are. And finally, there was lots of discussion about how previously we were doing this for 4 weeks in the hospital and how we might be able to move this to the outpatient setting and what kind of things are required to be able to do that in the outpatient setting. So that brings me to my conclusion, okay, which, as I say, it was exciting, lots of new data, definitely effective, lots of different options and ways things have been changed. Potentially new ways and quicker ways to develop the CAR T, but importantly, new ways to manage the side effects as well. Thank you.
Thank you, Faith, for that great overview. The final speaker on the myeloma domain this night before the Blood United speaker is Dr. Gareth Morgan. Dr. Morgan, too, is a world expert in myeloma. He's going to speak about hot topics. I know he is incredibly excited about what is going on in the myeloma field because he came into my office after ASH and was trying to explain to me that he might be out of a job simply because the therapies are getting so good, he didn't know what he was going to do with himself. But maybe he can explain that further.
Thank you, Michael. So this is a slide I put together trying to describe all the advances in understandings of how myeloma is initiated, how it develops as MUGUS, how it changes through smoldering myeloma to myeloma, and then to high-risk disease. And there's a whole lot of information on this slide, which I don't propose to go through, other than to say we're really beginning to understand the key drivers and to define new targets of therapy. But like everything in my life, the question is, will we ever need those new targets when we're doing so well with the treatments that we have available now? In the early phases of disease, I think there's some really important things that people don't really talk about, which is, can we prevent myeloma from happening? What causes it? How do we manipulate those things to prevent it? And then in people with MUGUS and smoldering myeloma, where they're followed up and told that they have a chance of turning into multiple myeloma, can we intercept the disease at that early phase and prevent it ever becoming cancerous at all? And then the big, the sort of multi-million-dollar question is, can we cure multiple myeloma? And I'm going to try and show you in the next slides that I think we're on the precipice of being able to do that. So this is an old slide, and it was building on what Mark has told us, which is showing you survival curves, which are very difficult for people to understand. But even back in 2014, we were talking about cure rates and saying that with good therapy, using all the treatment that was available, that 50% of people may be alive and well 10 to 15 years after they're diagnosed. What this slide also shows is that there are low-risk patients where it's much easier to achieve this. And on the right, at the bottom, there are high-risk patients where clearly current treatments are very ineffective and people don't survive long-term. So building on what I showed you in the first slide, these are the true drivers of myeloma and especially high-risk disease. And so those are laid out in the right of this diagram, but perhaps it's more accessible in the next slide, which shows the new International Myeloma Society consensus definition of high-risk disease, which I should say Dr. Davis was essential in pushing forward. And we can now recognize something like 20% of people when they first present to the clinic who should be treated differently because they're going to develop high-risk disease, and it's possible to adjust treatment to try and prevent that happening. This is just some more survival curves just to illustrate to you. This is a large French data set which shows the high-risk groups and the standard risk group. So the green curve is the standard risk curve. But you see, people are only in their first remissions a lot of the time at 50% at 4 years. And with upfront treatment these days, I think we should expect to get people to be in remissions out to 10 years. And so that's the standard approach that we use at NYU. And so again, if you have 1, 2, or 3 of those factors, you can see that the survival rates in the curve on the right fall dramatically with the greater number of high-risk markers that you have, until people with true high-risk disease are really relapsing before a year of therapy. So we have a lot to do in a way, but I'm going to show you what I think is the answer to this. Next slide. This is what has happened to treatment responses in the last, I can't do not 87 from 24, but in the last 20 years, I guess, of improvements in response rates. And so our standard induction regimen these days gives something like 95% responses and 60% undetectable disease or MRD negative diseases. So we're doing very well. And with this, the median survival, progression-free survival is something like 15 years, maybe less, maybe 12 years, but so much better than the 4 years I showed you in that last graph. This takes us back to Mark's slide to illustrate some points why I think this is showing us the best results we've ever seen. I think this data is better than what you see with a CAR T therapy. Something like 60% of people in MRD negative states where you can't find any disease at all, even with a highly sensitive test. And the top curve shows patients that are like, I believe it's like 83% of patients alive, well, in a complete remission 3 years after their first relapse. That curve looks stable, and if you extrapolate it out from there, patients may be cured. If you can imagine this moved to the frontline setting with very few side effects, we might be able to keep people alive for their natural lifespan. So really a big step forward when this is extrapolated by combining other agents into it. So this plus an IMiD should do extremely well long term. And I want to show you in the next slide what's happened with CAR Ts. This is the first CAR T study. And again, in the curve, you can see that something like 30 to 60% of people are alive and well at 3 years. So this is in a very bad group of people. But even in that setting, the press were harking cure for these very relapsed patients with CAR T. But when you move that forward, you can see in the top curve here where it says cilta-cel group, that curve is not as good as the curve we see with the daratumumab plus teclistamab. And so it does look as if the combination in a comparable set of patients suggests that we can spare people the side effect profile of CAR Ts in favor of a less toxic regimen, which is, I think, my final slide, which shows the toxicities of the CAR T regimens kind of versus the bispecifics. We deliver the bispecifics as an outpatient. Dr. Davis worked out a great way of doing this. It's well tolerated. We really don't see CRS or ICANS, the neurotoxicity associated with bispecifics that Mark talked about. But we still have a potential issue with CAR T therapy of late neurotoxicity. And I think it's always important to consider the efficacy versus the toxicity of the agents you use. So I'll wrap up there.
Let me turn it over for a few minutes to Andrea Nangle from Blood Cancer United, who is a patient and community outreach manager there, and is going to speak a little bit about some of the wonderful things that Blood Cancer United can do for our patients and others. So please go ahead.
Thanks so much. You may have heard of the Leukemia and Lymphoma Society, but we are now Blood Cancer United, if you have not heard already, as of August of 2025. So you will see our transition over the next 6 months or so before we begin to completely use our Blood Cancer United logo. I am the Patient and Community Outreach Manager and will be departing from Blood Cancer United on January 20th. But you will see Nicole Fortoso, who will be taking over my position and ready and willing to help all of the patients on this call that might want to get connected to our resources. So the mission of Blood Cancer United is to cure blood cancer. It is also to improve the quality of life for patients who are living with blood cancer. As you know, patients can live with blood cancer, fortunately, for decades. And we want to make sure that that time period is one in which you have the support that you need, whether that's financial or emotional, or maybe it's extra education that you know you can rely on. Our new website is out. I hope, will find it easier to navigate as you go to your diagnosis. And then within that page, you will find series of guided questions, resources, 3D models, you name it, we have it. You can look at a variety of our resources that we will talk about tonight, as well as, and we will not go into our research and advocacy as much as I'd love to, but you can find additional information on our website, including who we fund and where they're located. So this is for those of you on the call that are medical professionals. We do offer in-person and virtual and recorded CE and CME credit courses. We do have some coming up in New York City, for example. So check it out, webcasts, podcasts. We do have a podcast both for patients and caregivers, as well as a podcast for healthcare providers. Strongly encourage you to check those out if you haven't already. And we will have our blood cancer conference March 14th in New York City at the Marriott Marquis, which, while mostly focused towards patients and caregivers, is a fantastic opportunity for healthcare providers to listen in, meet people in the field, see the exhibitors, listen to the keynote, etc. One of the key parts of our organization is the Information Resource Center. These are social workers and nurses. So I know you see that 800 number and you get a little nervous, who am I calling? But they really are my colleagues who are lovely. They've been in the hematology oncology field on the ground, and now they've transitioned into a virtual role. So they're working across the country. When you call the 800 number, you will be connected to them, and you can ask questions. They can guide you through your immediate concerns, as well as kind of prompt you to think about things that you might want to be prepared for. Clinical trials, some of you might be curious as to just what it is, and then others of you might want to go a step further and say, maybe I want to get connected to a trial. What's out there? And so this is the only one that we know of in the country for blood cancer. It is our colleagues who are clinical trial nurses. You can get connected to the clinical trial nursing navigators. They will teach you about clinical trials. They can also put together a packet of trials you might be eligible for that you can take back to your medical team. And then if your doctor says, yep, that looks good for you, I would look at trial A, we will help you to overcome barriers to connect with the private investigator and to get enrolled. Regardless of what type of cancer you have, this is just a note that we do offer free nutrition consultations with our dietitians. So you are welcome to call whether or not you have a blood cancer. We do accept phone calls from folks with any type of cancer. The resources on the website are also fantastic if you're looking for recipes and other resources. This is the most popular program. This is a peer-to-peer program. So we have over 800 trained volunteers who are either caregivers or patients. And whether or not, let's say you're a parent of a young child or an adult child of an older parent, we can find a match for you most likely. And this conversation, whether it's one or two conversations, seems to really be a game changer for patients, especially those going into maybe CAR T or BMT, bone marrow transplants. They really want to talk to someone else who's been through it. And so this is, again, you can call our 800 number and get connected. If maybe you're someone who would rather go online and chat with people, maybe join a group with someone of a similar diagnosis, you can go into the patient community and sign up and create a profile. And we have tens of thousands of people across the country, all focused on blood cancer. So most of these are patients and caregivers or family members. It is a fantastic way to go to a safe space to, whether you observe the discussions or participate. It is just a great way to connect with people that might have a similar experience. Support programs, I do get more and more calls these days for in-person. We don't know of many in-person or any in-person at this point, but we do have several virtual support groups that you can join. We also have online chats that is more of, you can think of it almost when you chat during a Zoom meeting. That's what you'd be doing on our online chats, and they're moderated by social workers. And then we have a great deal of support for caregivers. So if you're a caregiver on this call, please give us a ring, because we do recognize you are equally important in the success of any treatment provided to patients. And then for my last couple slides, I wanted to mention what everyone's probably wondering: do we have money? And so we do have financial support. We have several programs. I will warn you that they do open and close. So you might check today and a program could be open and you check, 2 days from now and it's closed. So just put something on your calendar to remind yourself to check our website and you can see what is open and applicable to your situation at that time. This medical debt case management program has been a game changer. We started it about a year ago. We have helped to resolve, as in get rid of, over $4 million worth of debt for patients. So this is a free counseling service. You will get a one-on-one counselor to just discuss with you how to prevent debt or manage the medical debt that you currently have, and hopefully to get rid of some of that debt if that's possible. So these are angels. I don't know how they do it, but this has been incredibly successful for many people. So I encourage you to give us a call. The number is on our website. You can still call that 800 number and they'll connect you. Or you can get the direct line that you see on your screen from our website. And this is just an example of some of the booklets we have. You can download or order to your home for free. And like I said before, there are many ways to get the information based on what kind of learner you are. So if you're audio, we have our podcast. If you're visual and auditory, we have our webcasts and videos. And then we have our fact sheets, nutrition handbooks, educational booklets. You can see bloodcancerunited.org, get involved. There are many ways that you can connect with us, whether it's as a volunteer or maybe you want to share your story. You can go on our website and share your story, and that will be reviewed and then posted on our website. You can connect with an information specialist. Or let's say you want to join our fundraising campaigns like Light the Night or Visionaries of the Year. You can also do that as well, all by just calling our phone number, and we will get you connected to the right person. Last but not least, a plug again, Blood Cancer Conference, March 14th. Leading experts from around the New York area will be highlighted there. And if you want to volunteer, you can do that as well. So thanks so much for your time today.
Thanks so much, Andrea. And now we're delighted that we can have a brief presentation from Mr. Cannon, who's a multiple myeloma survivor and a patient here. And Alan, please take over and tell us a little bit about your story.
Good evening. My name is Alan. I'm a patient of Dr. Bronstein, and I'd like to say good evening to you, everyone. I had the CAR T-cell therapy about 90 days ago, and it seems that it's working very well for me.
Little side effect.
A couple side effects that have given me a little problems, but besides that, it's been a wonderful experience. I thank for Dr. Bronstein for his help and Dr. Braun for his help.
Everyone came.
And it's been a journey. Thank you all.
Thank you for taking the time to share your story, and so nice for all of us to see that the CAR T seems to have been effective, and that you're here talking to us. That's really wonderful.
Amen. I mean, there are some side effects, but I get bad diarrhea. I have problems sleeping sometimes, but I'm getting past it. And as time goes on, I'm hoping that I'll be normalized.
We hope so too.
Good for you.
I was going to say it's
I
it's
don't
a
think
clear
he'll ever be
team
normalized.
approach. I was gonna, yeah, hello.
He's never going
It's
to be
a true team
normalized.
approach.
We're also all eagerly awaiting Dr. Morgan being normalized, but
Yeah.
I think
It's
there's
going to
more
take
hope
more
for
than
you.
a coffee for that.
I
Thank
can't
you so
wait for the
much.
summertime to go out to cook and go swimming in my pool and all the things that I love to do when the sun is out.
Good for you,
That's
Alan.
nice.
Thank you.
And I have to thank Dr. Bronstein. He is fantastic.
Thank you.
Oh, that's
Thank you for
great to
sharing your
hear.
story.
There have been as we've been sitting here through this, there have been an enormous number of questions in the chat, and I appreciate all the panelists taking the time to answer them. But I thought maybe we could use the last few minutes to highlight some of these questions and the broad areas that they fall into. One thing that I would like the panelists to address that seemed to be a common theme among the questions is, with all these new therapies we've heard about, someone asked a specific question based on the results of Majestic 3, for example. Would you now use this type of therapy before CAR T? And then another theme of the questions are, can bispecifics or CAR T for that matter just replace transplant? What is the result of what is the impact of all of this on the therapies they have available? And I'll let each of you kind of try to tackle that question. You may have different
Thank
views,
you for
but
that.
I think it's important thematically for where does transplant go? When do we sequence these? What do we do? That was a common theme among the questions.
So I'm going to start this off because I have the most vested interest in transplant because I was on the first trial that showed there was a benefit for transplantation compared to previous standard treatment. And over the years, transplant replaced and became standard treatment. But I feel it is about transplant's time to go through that process. The current treatments are less toxic, they are more active. We can plan to do a transplant if needed, but I don't think the time really is still there for transplant upfront. I don't think it's right immediately to step away from it, but its time is limited.
Faith, Mark.
So I think the new data that Mark showed about Majestic 3 has thrown everything on its head, because prior to ASH, the general feeling was that if you had a CAR T cell or a bispecific, that maybe you should do the CAR T cell first and then do the bispecific later. However, the data of the Majestic 3 showing how good the combination of the bispecific with the daratumumab has now got everybody thinking, okay, what order should we do these things in? And I suspect over the next few years, that's going to be one of the big clinical trial questions is there a best order and how should you do it?
Yeah, I mean, what's emerging, I think, is that
Sorry, Mark. I'm going to say maybe we won't need an order in the future. But when we get it right up front, they'll be in a remission for so long that we won't have to go around this endless debate about the sequencing of therapies. Sorry, Mark.
No, it's a very fair point. I was just going to say that I think what's emerging is that using these T cell redirecting therapies in earlier settings of the disease is even more effective, and that might eliminate the need for a transplant if as Dr. Morgan said, if we're prolonging their survival so long by using these CAR T cells and bispecifics up front. As I mentioned, we have the TEC-7 study, which is looking at bispecifics in patients who are willing to defer transplant. And then there are also studies looking at CAR Ts in the upfront setting compared to transplant. So we may have answers to some of these questions in the next few years.
I think another common theme that I saw among the questions was the concept of de-escalating therapy, or how long do you need to be on therapy? Does it need to stay at the same intensity of therapy? And what is the role of something like minimal residual disease in determining the duration of therapy or the intensity of therapy? What are roles for things like ctDNA? So maybe you all could comment on
Back in the day,
what's that?
I said back in the day, chronic myeloid leukemia was an interesting kind of therapeutic challenge. And once the appropriate treatments had been discovered, it all became about, can you de-escalate the treatment? When do you stop the treatment? When is enough? And of course, MRD technology helped in that process. but we're not quite there in myeloma yet. We have to finish this tranche of studies before we go towards looking about the safety of therapy and how long do people stay on therapy. We're not quite there yet in myeloma, in my opinion.
So you all agree on that one, or is there some role for backing off a little bit in people who have achieved MRD?
So I think kind of there wasn't a lot of data presented at ASH about this, but there is a general feeling now about this term called sustained minimal residual disease, which is where you measure a very sensitive level or measure to a very sensitive level and see if you can see any myeloma. And if you can't, and then if you repeat that at a year's interval or a 2 years interval, if you've had a couple of readings where you really can't see any myeloma, that actually stopping therapy may be appropriate. And so I think that's important. The other important thing is exactly as you say about de-escalation. The reality is we all actually do a lot of de-escalating, be it that we go from, the weekly daratumumab to every 2 weeks to once a month, or we maybe drop the dose, because certainly we need patients, we need the therapies to be tolerable, we need patients to have minimal side effects, and we also need patients not to be in the hospital all of the time. So I think it's always that balance, but it is something definitely that's important.
Here's a question that I don't think anybody asked, but I'll ask. When do you think we will get rid of bone marrow biopsies for this disease?
So why do we need to get rid of them? I guess
Well,
I kind of know patients going
people
to
don't enjoy having them.
well, it's a mixed bag really. So does circulating tumor DNA assessment work in multiple myeloma? And it's not there yet. You certainly can't use it for minimal residual disease. And so at some level, if you want the information to be able to guide your treatment in terms of stopping treatment and getting the best treatment, currently I think we're stuck with where we are. Should we be using anesthesia? Probably we should.
Okay. Everybody else agree with that? Any role for de-escalation of bone marrow biopsies?
I mean, I would say that, you can run the MRD test on the blood, but it's not really minimal residual disease. It's about 100 times less sensitive than doing it on the bone marrow. So there is value to doing the bone marrow biopsy and specifically doing the MRD assay on the bone marrow. There are studies looking at other more sensitive tests than our routine blood tests like mass spectrometry, which looks at proteins of the myeloma and is much more sensitive than your typical like SPEP or serum protein electrophoresis, but they're not yet standard of care for surveillance.
And I thank everybody for taking their time to join and to learn, and for those of you who are patients, all of our speakers are always available to answer questions, are always available to see people. They are active, and not only as researchers but as clinicians, and our cancer program spreads across 3 campuses in Manhattan, Brooklyn, and Long Island, and we have people with disease expertise in each of those areas. So we're always happy to continue an ongoing discussion with our patients.